All right, chapter 33. This chapter, you will need your book to follow along with. Feel free to take any notes. We're going to go over some key nursing concepts. This chapter is titled Pharmacology and the Preparation for Drug Administration. Guys, medication administration is a highly stressful time, to be honest. Can't sugarcoat that, okay? When you're doing a med pass or a med administration or distributing meds to your patient, passing medications, it's a time where you need to minimize distraction. It is a time where you need to focus yourself entirely. All right, let's get into it. So, what is our objectives for this lesson? We're going to talk about the different drug classes and their actions because the best way, the most effective way to learn medicines is by the class of medicine. What do I mean by class? For example, your class is PNR104. If somebody was coming into the facility and said, hey, where is PNR104 at? Oh, it's right over here. That's the class. The person may not know each individual's name in the class, but they know what the class does, so you are associated with the class, if that makes better sense for you. We're going to talk about the legal implications of administrations, okay, as far as your scope of practice as a nurse, because everything we do has a legal aspect to it. We're going to talk about the actions of drugs in the body in a general format, so this is an introduction. We're going to talk about certain concerns regarding medication administration, regarding children, older adults, or geriatrics. And we'll analyze different uses of medication in the home environment because home health nursing is just a smidge. There's different considerations when you're doing a med pass at home in home health versus med pass in acute care of the hospital. All right, so what is pharmacology? This is learning about drugs. This is the study of drugs, the study of medicine, okay? Medicines have been used throughout time in history, okay? For example, penicillin came up kind of by accident when a gentleman grew mold and realized that the mold that he grew was penicillin, and it actually helped fight off harmful bacteria. Okay. Opium has been used, that is derived from a pretty flower, okay, poppy, all right, poppy seeds, that is opium, etc. Okay. Because of the vast increase in pharmaceutical agents used for medication treatment and the multiple drugs that many patients take, this is why nurses, we have to be knowledgeable about drug effects, side effects, drug interactions. For example, when a drug modifies the action of another drug, that's a huge ordeal, right? Anyone who is allowed or licensed to administer medication needs to be aware of every aspect of that med. Okay, doctors prescribe, pharmacists dispense, and nurses administer. Okay, so therefore we are legally bound to the patients regarding the effect that the drug will have on them. We don't just, because the doctor ordered something, we don't just go grab it and give it just because the doctor said no. We are a profession. We are professionals. We are educated. You are becoming educated in the field, and you will know what is proper and what is not proper, and what is legal and what is illegal, what's in your scope and what is not. But again, right now is a general introduction. We're going to talk about what the 6 rights of medication pass are, because there's a protocol to follow. There is an absolute protocol to follow when you're doing medication pass. Okay, and that is imperative. There's no option about doing it. That is what will be done. The next thing we're going to get into is talking about what are some key terms that you need to know. Okay, you're going to need to know the key term anaphylaxis. It's on page 635. Actually, page 641. Pardon me. Excuse me. Anaphylaxis. What that means. Going to need to know agonist. Again, on page 641. Black box warning 642, drug interactions 635, half-life, pay attention to half-life 641. Page 648 has your medication administration record and what that is important to understand. All of these terms are important to understand, but I'm highlighting some of the ones that we're going to talk about specifically. Okay. You need to know what a generic name and a trade name is. We're going to go through what that is. Now, in your education as a nurse, you have a few aspects that you're responsible for. No pun intended, right? We need to know the appropriate dosage. What's saying here on your slide, generic and trade name. Okay, so your generic name is a name that is the chemical name of a drug. Have you ever seen a bottle of Tylenol? I'm sure most people have, right? That's like a go-to when you live in the States and other countries, but in the States, predominantly, it's like, oh, headache, grab an aspirin. Your foot hurts, grab an aspirin. Somebody looked at you wrong, grab an aspirin. I should have said Tylenol. That's what I mean, Tylenol. Anywho, nonetheless, a Tylenol. Tylenol is a trade name. Also called proprietary name. It's a name. Tylenol is owned by a company. It is a trademark. It's protected. It makes the company money. Okay. A generic name is not protected by a trademark. It is the chemical composition. For example, Tylenol is sold under the generic name as well as acetaminophen. Acetaminophen is a generic name because it has to do with the chemical composition of the drug. Okay, no one company owns the name acetaminophen. They own the name Tylenol, and I believe that is the Johnson & Johnson company, but don't quote me on that. Now, when you're giving a drug, you have to be knowledgeable about the therapeutic effect or what you desire the drug to do. If somebody has a headache, you may want to grab a Tylenol, right? That's what a lot of research has shown. Tylenol can help with pain. It is an analgesic, which means a pain medicine. We want to know that the therapeutic effect of a Tylenol is your headache's gone. You come back and you follow the nursing process, meaning the last portion is evaluation. You ask your patient after they had the Tylenol, hey, how's your headache? If it's gone or reduced, it's therapeutic. Adverse reactions we need to know, and side effects. Okay. Now, let's continue here. So you got a couple names to work with. I had said the chemical name, which is the generic. Okay. Again, not protected by a trademark. This slide just kind of explains what I just talked about. Now your drug classes. This is where the table 33.2 on page 637 is going to come in very handy, and table 33.1 on page 636. Okay, the best way. So again, the classification of the drug is how it is defined. Okay, for example, it is extremely important to learn medications with a generic term and a trade name because you never know. Okay, come. Give me 1 second, I'll pause. Okay, so as we were saying, these drug classifications are going to be important to understand. We need to learn to categorize medicines with similar characteristics, which you'll find in their class. Classifications may be defined by the effect of the drug in the body, for example, like anticonvulsants, as it says here, or symptoms the drug relieves, like high blood pressure, anti-hypertensive, right? That's what we're talking about: anti-inflammatory, analgesic, anti-clotting properties, or anticoagulant, which is like a blood thinner. Our nursing implications help us to make sure it is safe. Your NCLEX is a safety exam. We need to make sure that we provide effective and safe and effective administration. So here is a list of the control of medications. Some of us have a pretty good idea of what this is, just generally going through life and being in the medical atmosphere. If you've ever been sick, gone to a doctor, urgent care. Here's who can prescribe medicines: your physicians, dentists, osteopaths, and veterans. So what's the difference here? You ever seen a doctor with the credentials MD at the end of their name? Well, yeah, right? Doctors, they have a medical doctor. But then you have doctors who are osteopaths, or their credentials end in D, like dog, O at the end of their name. They're still a doctor. They're just osteopaths, which is about a different route of becoming a physician. And your veterinarians. Other people who can prescribe medicines, but they have to work with a doctor, are PAs, physician assistant, your nurse practitioners, and advanced practice nurses. Okay, advanced practice nurses, anyone with an MSN or above, depending on their clinical implication, are they an NP? Have they taken their boards to be a nurse practitioner? Okay. Now, who regulates all these drugs? Where do they go? How do they come about? How are they managed? Okay. Well, as we know, the hospital is responsible for the security of. Okay. So they secure the medicines. Let's see here. The Food and Drug Act. Let me find what page that is on. Bear with me. Here we go. Page 638. Please see table 33.2 as well. Just a general read over on that table. Okay. Now, the Food and Drug Act of 1906, the Federal Food and Drug Cosmetic Act of 1938, and the Comprehensive Drug Abuse Prevention and Control Act of 1970. These are the people who manufacture and regulate drugs. Now, schedule of drugs, okay? You may have heard that maybe narcotics are a Schedule 2 drug, okay? Schedule 1. Here's some examples, okay? A Schedule 1, the higher the schedule, the lower the schedule number. So for example, Schedule 1, it means that these are drugs that are not accepted by the medical community. We don't prescribe them. We don't use them, okay? We do not utilize these. You will not be administering these. Like, no doctor is going to order ecstasy or heroin, okay, or LSD. All right. I'm not going to touch on medical marijuana right now because this is a general intro, but I'm including the latter of. Okay. So some opioids, some psychedelics, even some cannabis derived. I'm not going to go any further than that because a lot of things are changing in that aspect, but there's still a Schedule 1 drug. It's not accepted in the medical community generally, and it has like extremely high potential for abuse. Okay. Now, Schedule 2. You can use these in the medical field. Oxycodone, fentanyl, codeine, hydrocodone, right? Adderall, Ritalin. Those are some example. Barbiturates, okay? Those are methadone. Those are some examples. Um, Even some cocaine is in this as far as um, helping people come off of the drug. So Schedule 2 has some medical use and has a high potential for abuse. Okay. Schedule 3, again, medically useful. They have a less potential for an abuse, and I'm getting the information here from the chart on page 639, table 33.3. Schedule 4 and 5. 5 being the lowest for potential abuse. If you can remember, Schedule 1 has no medical necessity and it's highly abused, and Schedule 5, where it has the lowest potential for abuse and it has medical use, that's the best thing to remember, the schedule of drugs. Okay. Now, I'm just verifying one thing. Bear with me real quick. Here. You are not tested on the drug schedule. Okay. In order for drugs to be approved, they have to become a part of these 5 areas. Hang on. They have to be a part of these 5 areas. Their purity. How pure is it? How potent? Means, is it going to work when it gets in the system? Bioavailability, that refers to how well, again, it is used and absorbed by the system for it to work effectively. Efficacy and safety, those kind of go hand in hand as far as drug related and how they pass their drug standards. Okay, what do we use drugs for? Right, those Schedule 1 drugs, those have no medical use, so people use those for their own recreation, right? Abuseful needs. What we really should be using drugs for is what's here. Treatment, palliation, means relieving pain. Diagnosis, cure, and prevention of disease. Now, some of the basic concepts of pharmacology can be broken down, right? Regarding pharmacokinetics, how is the body really going to metabolize or break it down? Okay, knowledge of pharmacokinetics is used by nurses in timing drug administration. Nurses judge the patient's risk for alterations in the drug action by considering physiologic conditions and other medications the patient's taking. Basically, how your body is going to break it down and get it out. Okay? You need to know half-life. That relates to pharmacokinetics. Okay, and absorption. Now, absorption, got some determining factors here regarding absorption. That is how person's weight, age, gender. Okay, what diseases they have. Maybe genetics is going to take a role in that as well. Or their immune system. Are they a cancer patient where the immune system is just run down? Do they suffer from a genetic disease that's going to prevent them from absorbing the medicine the right way? Even with distribution. Okay. Now, distribution. That has to go, every medicine has a target organ. Every medicine has an action to do. It has a job. And it depends on the chemical and the properties of the drug. It's kind of like the vehicle of medicine delivery into the organs, if you will. Where does it go? How does it work? It's kind of like UPS. This big package that's coming in has to go to this area. This little package that's coming in has got to go to this area, right? And then it's separated. Okay. Here's a nice picture on how drugs work in the body. Okay, so we have to think when we're given a drug, what's going to be the safest way to give the drug and to manage the drug within the patient. Okay, Are they presenting with clinical findings? Like, how's their vital signs? Is that going to be like a contraindication or a reason why you would not give the drug or why it wouldn't be safe? For example, if you had to give a medicine to reduce the heart rate, okay, like an anti-arrhythmic medicine, and you check their radial pulse, or you better yet, you check their apical pulse, and it's like 50, would you give it to them? Is it going to make their condition worse by lowering that heart rate? Because we know the normal heart rate is 60 to 100 beats per minute. So you have to take that in effect. That's clinical factors. Administration, what form the drug is. Is it a pill? Is it a ointment? Is it topical? Like, does it go on the skin and absorb? Is it a patch? Is it intravenous? Is it an injection? Because all those have different methods of absorption and different durations in the system. For example, that leads me down to pharmacokinetics, the absorption, which is how it gets into the body. That takes time, right? Each route of the drug administration between administration and pharmacokinetics has a different time that it'll be readily available. For example, the general thought is if you swallow a medicine orally, it's probably going to take about 45 minutes for you to digest it, and then it could be even further slowed down depending on the mechanism of action of that drug. Okay, once you get into pharmacology and you start learning how to read your drug book, this will make better sense. But for now, this general intro will give you the foundation you need to get into pharmacology next term. We need to think about, when we're giving drugs, how many drugs the patient's already on, what they're taking. Is it going to have an effect on them? Is it going to have an interaction with them? Those are substantial things to think about. Side effects, adverse effects. Therapeutic range or window. Now, regarding peak onset and duration, that is something we want to make sure we know. As far as for right now, insulin and what insulin is. We're going to get into that too in the chapters 34, 35, 36. Okay. So when you're preparing to administer medications, you need to include an assessment as a part of the medication administration process. You need to know why the client's getting the drug. That means indication. You need to know the client's knowledge about each medication. Okay. You need to assess the potential interactions among the drug the client is receiving and any client allergies. Okay. Those are important to include as a part of your medication administration process. Okay. Let's see what else I got here. Continuing on, I'm on page 641. If you're following along in your book. By understanding the terms on page 641, peak action, half-life, peak draw, agonist, antagonist, this is just memorization at this point, ladies and gentlemen. This is teaching you how to understand pharmacologic terms, okay? I'm going to get into the slide in just a minute. I'm going to digress real quick and talk about chapter 33 on page 641. The onset, peak, and duration of action differ from each drug. Peak occurs when the highest blood concentration or plasma concentration is achieved. So, for example, the length of time the drug exerts or gives off a pharmacologic effect is the duration of action. Okay? The onset of the drug begins when the drug reaches a minimum effective concentration level. Each drug has a serum half-life, or basically the time it takes for the drug concentration to decrease by half because of excretion, whether it's fecal excretion, defecation, or in urine. Because the first pass of a medicine, first pass effect happens through the liver. You swallow a drug, right? Goes to your stomach, stomach absorbs it, goes through your intestines. The idea of the drug, it needs to get into the bloodstream. That's the goal. And no matter what, obviously intravenous is going to be the quickest method to the bloodstream, but each of these medicines has to reach the bloodstream to get to the target organ that it needs to reach to work properly. Okay? Why are these so important? Well, if you have, especially if you have a patient on multiple meds, you may not want the meds to peak at the same time or reach their highest blood plasma concentration. So, for example, if you have a patient that took 3 Tylenols for some reason because they had a headache at home, and then all of a sudden they're like, within an hour, that an hour later they say, I think I'm gonna go take my my other medicine. And the nurse may say, what's your other medicine? They say, oh, well, I'm gonna go take Percocet for pain because maybe they just had surgery. Well, we need to think about that because we don't want Percocet, which has Tylenol in it, to peak at the same time the other Tylenol is peaking, because once Tylenol reaches over a certain dosage, it will injure your liver, which can be life-threatening depending on the severity of it. Okay? Understanding that drugs produce a response, okay, are agonists, and drugs that block a response are antagonists. You will need to know those for exam number 4. Okay? Again, half-life is the time it takes excretion to lower the drug's concentration by half. Okay? That is important to know. Agonist is something that produces a response. Agonist. Drugs that block a response are antagonists. Okay? Let's get into this slide. So, if we have, these are all routes of administration. Transdermal, or on the skin, is one of the slowest method of absorption. That comes in the form of a patch. Okay? There's different types of patches. Right now we're going to keep it simple and go with that it is a patch on the skin that is very slowly absorbing. Another route of administration is through the mucous membranes. That's kind of quickly absorbing, not as quick as IV, of course. Mucous membranes. So where do we have mucous membranes? In our mouth, in our eyes, okay, in our nose. When we're doing eye ointments or eye drops, that's a mucous membrane. When we're doing a nasal mist, maybe like a Flonase, that goes to our respiratory tract as well, but also the nasal membranes, okay? If we do sublingual, which is under our tongue, our mouth has moist mucous membranes, that is quickly absorbing. Or if we do subbuccal or buccal, okay, which is in our cheek, again, that's in our mouth, that is a mucous membrane. Oral is when you swallow medicine. That's one of the slowest methods. That's probably at least an hour, depending on size of your patient, if they've eaten anything, what they've eaten. Okay, what other meds are they on? Intramuscular, that's when you're delivering medicine right into the muscle. Okay, that's going to take some time for it to absorb to the bloodstream. But this one gets a little tricky because it depends on whatever medication that you're giving to your patient. Okay. Subcutaneous, that is into the subcutaneous layer of the skin, that last layer of the skin that has that adipose tissue, that is a slow method of absorption. It's going to take a little bit to get to the bloodstream from the subcutaneous tissue. Intravenous is going right. Intra is Latin for interior or entering or in, and then venous relates to the vein, right? So if we have intravenous, we have medicine delivered intravenously right into the vein. That is the fastest method of absorption because it is delivered right to the flowing blood stream. Now, what else do we have? biologic membranes. Let's see here. Let's go into this. But before I get into this slide, I would like to explain some more of the book first. I want to talk about side effects on page 640. Okay. The primary effect is the desired effect. So I take a Tylenol, my headache goes away. That's desired. The secondary effect may or may not be desirable or undesirable, causing a side effect that is unintended. So side effects, guys, are unintended effects. Let's say if you took a medicine, maybe you got nauseous afterwards. That is a side effect, okay? Now, there's also adverse effects, which is under considerable undesirable effects with serious consequences. So, for example, somebody starts taking a medicine that maybe it's going to cause pancreatitis. Okay, inflammation of the pancreas. That is substantial. So it's not just your headache, nausea, vomiting, diarrhea. It is worse than that. I'm going to pause for just a moment. Okay, pardon my pause. Thank you very much for that. Let's talk about what is going to affect drug action. Okay, I said earlier people taking more than one drug, like we call that polypharmacy, taking more than one drug, poly meaning many, pharmacy meaning relating to medications. What can happen if people start having adverse effect? Your kidneys, your liver can get affected if there's a toxic level of drugs. Okay, most medicines are excreted through voiding, most of them. So if we have our kidney affected, we've got big problems. If our liver is affected, we cannot metabolize the medicines the right way. Okay. People who are dehydrated, okay, or inadequate fluid intake. We talked about I's and O's, intake and output. If they are not taking a substantial amount of intake, that could affect the way the drug reaches its level, its highest level. Okay, it might become toxic at one point. We talked about this. Please feel free to review this slide. Let's see, 4 types of drug action. Here we go. Okay. We're going to talk about, now you can find that on, some of it is on page 640. It talks about how most drugs cross the placental barrier and affect the fetus. It talks about some drugs binding to proteins called albumin. Okay. Once the drug reaches the site of action, the drug metabolizes into an inactive form and becomes easily excreted, meaning the drug is going to degrade or break down and remove those active chemicals. If we I can't go back to the slide. If our liver was affected, when liver function is decreased because of disease or aging, drugs may be eliminated slowly or more slowly than usual, resulting in the accumulation of the drug that can lead to toxic levels. So I just wanted to, that's what I wanted to digress on that and really just explain that. Um, let's see here. I think that was it on this page. Sorry guys, there's a lot of information on page 640 and 641 that I wanted to go into detail with. Regarding concentration of medicine, we need to think about the blood-brain barrier and how this is permeable, or meaning drugs can cross. If they're fat-soluble drugs, those can reach the brain and the cerebral spinal fluid, or CSF fluid. This is going to make more sense. I know in nutrition you've talked about water soluble and fat soluble. So fat soluble can cross the blood-brain barrier, which is why some narcotics will affect the central nervous system, because they are absorbed and they cross the blood-brain barrier, producing the effect of lethargy, euphoria, being tired. Your muscle movements are slower because it crosses the barrier and affects the central nervous system, which is affecting our entire body at that point. Okay. Let's see. So we're going to talk about that. Now, I want to tell you an interesting fact. Alcohol and gaseous and volatile compounds such as anesthetics, okay, so your anesthesia, are excreted through the lungs. Fun fact. Deep breathing and coughing helps the post-op patient rid the body of anesthesia more rapidly. So drugs do metabolize in the liver, may be excreted into the intestine by bile. Bile is produced by the gallbladder. The chemicals may be reabsorbed through the intestine. Therefore, an increase in peristalsis. Peristalsis is the how your gut is working. So, for example, it's like a wave-like format that your stomach and intestines are all moving. So, let's say you swallowed a cheeseburger. Okay, you not swallowed the whole cheeseburger, guys, but you went to Burger King, you ordered a cheeseburger, you start chewing on it, eating it, right? Bite by bite, right? Nothing crazy there. You're eating it bite by bite. It's going into your stomach. Your stomach has hydrochloric acid in there and is going to help break it down, because what your body, our taste buds are telling us one thing, but our body is looking for the nutrients in that cheeseburger, which there really isn't none, but that's what it's looking for. So it's breaking it down. It's going into your small intestine, large intestine, duodenum, okay, through the cecum, all the parts of your intestine, your GI tract, okay? So the peristalsis is the wave-like movement of food throughout your GI tract. Okay, so when we have an increase in peristalsis, this accelerates drug excretion. Now, some factors that slow peristalsis may prolong the drug's effect. Okay, same thing. Some drugs are excreted by the kidney are unchanged, but most are metabolized and excreted by the liver. So that's what we're worried about. If kidney function declines, drug excretion kind of drops and it places the patient at risk for toxicity. If we have adequate fluid intake, we can eliminate drugs properly. So now we can move on to this slide. Okay, so the 4 types of drug action is stimulation or depression. That is where it gets to the target site and it starts doing the work. Okay. You have some secretion going on, you have some functions happening with the drug. Now you can get another type of medication, a drug action called replacement. That is insulin, okay? I need you guys to know about insulin. That is a high alert medicine. It needs to be checked by another nurse before administering it to the client, okay? Just make sure you know that. There's other types of insulin that the nurse can give too, but we'll talk about that. Some insulins, like NPH insulin, are cloudy. Now, regular insulin is clear. Those are replacement for people who don't produce their own insulin. Now, antibiotics are killing of organism or inhibition. That works by blocking synthesis or meaning creation of the cell wall. We'll get into that. And irritation. That's where if somebody is, let's say peristalsis is really slowed down, they're constipated. They're going to need a laxative, okay? It works on the wall of the colon, increases the fluid that comes into the GI tract, and that gives you a laxative effect. We kind of talked about this already, that food in the stomach can affect the drug, okay? We talked about the delays, the gastric juices. Let's see here. Some drugs are incompatible or have an additive effect or a synergist effect, meaning they're going to work together and increase the effect. We're going to get into that in the latter chapters. Here we go. Medication administration safety. What are you doing to make sure your patient's safe? You have to triple check that drug order. You have to make sure that it is safe for your patient. Is this what they're getting it for? Is the timing right? You're going to go through your 6 rights of medication administration. Okay. Page 643 has a wonderful table on routes of administration as well. Let's see here. Let me pause on the slide and go into your book. Page 642 has a medical terminology you need to understand. It is called the black box warning. Why does this matter? A black box warning is the strongest warning by the FDA that the medicine can still carry and remain on the market in the United States. Okay? So the black box warning is to alert the patient and the healthcare provider about safety concerns like serious side effects or life-threatening side effects. But it's still on the market. It's one of the highest alerts that we have, which means the drug can still stay on the market, even though it has that potential side effect, or adverse effect, I should say. Life-threatening side effects. These are red. These are red fonts in your drug book, okay? Again, that is the strongest warning that a medication can carry and remain on the market is the black box warning, okay? Okay, here we go. What else here? Synergist effect occurs when the action of 2 drugs combined is increased or greater than the effect of the drug if it was given separately. So, for example, this is why you don't drink alcohol and take a narcotic, because it depresses the central nervous system or the CNS symptom. That can really cause some life-threatening effects there. You do not want to do that. You must analyze the physician's order to determine whether the drug, dose, and timing of the drug are appropriate for the patient. For this reason, you got to be aware of the usual dosages, right? Like, is that a normal dose? Does it not sound right? Let's double check. It is okay to keep your drug book on you when you work. That is fine. Okay? Remember that going back to agonist, that it is a that produces an effect, and an antagonist blocks an effect. Okay? Remember in the review, I also talked about a drug that inhibits the clotting of blood. That is an anticoagulant. Anticoagulant. Just making sure I'm hitting my key points that I have noted down here. Okay? Antihypertensives, what they do, they help reduce your blood pressure, right? Makes it therapeutic. Now, I'm focusing right now on page 642, 643, because these are a big chunk here. There are some considerations while providing med administration and safety. If you make a med error, it can be life-threatening for the patient. The safety comes first. I'm telling you right now, Most of us will make a med error. Okay? We are human. It happens. Okay? You need to make sure your patient is safe at all time and be hyper vigilant. Hyper vigilant. Okay? That's why when we talked in the earlier chapters, 4, 5, and 6, we talked about computerized provider order entries, CPOE. Those helps reduce the number of medication errors. So again, if a doctor gives you orders, please make sure if you have CPOE capabilities that they put in their own orders. That helps. We have to monitor lab values. I gave you guys that handout. You need to know that those lab values before you get into foundations, and certainly before Med-Surg 1. That is a hint, hint, wink, wink for your next term, okay? No, you're not tested on lab values right now. Of course not. It wouldn't make you suffer that way. But on the break, you will look over lab values. For PNR 106, your foundation course, that's coming up next term. Okay? But I do want you to check out table 33.6 on page 643. Okay. Now, the consideration for infants and children, those are weight-based drugs. Okay. Generally, we do not round these. These are exactly, we don't round up. We don't round down. It is exact dosage. It is weight-based. It goes by age, size, and weight. Okay. Again, it's not a standardized amount. It is weight-based pediatrics. Okay. When you're dealing with peds, when you get to peds, I'm not going to talk about peds too much right now. You need to make sure you talk to the parents if they're available for the least traumatic way to give them. The mom and dad know, or the caretakers know how to give the child the drug the best way. Try to give medicine to a 2-year-old. It is like trying to nail Jello to the wall. It is the hardest thing ever. Do not tell the infant or the toddler or the child that it is candy. Not a good practice. Absolutely not. That is when they will go into the medicine cabinet and remove a top and accidentally overdose because you told them it was candy. Be vigilant. Do not confuse medication and do not say that it's candy. It is illegal to do that to adults. That is called a placebo. That is illegal. We do not do that. You have to say what the drug is and do not do not mask the drug. Okay? It is what it is. Pediatric nurses routinely double check and recalculate all drugs that are ordered by providers. That's why math is extremely important. Okay? Among all the populations. If you make a medication error, there is a phone number and a website you can go to report it. It is on page 643. You do not need to know that for your exam, but that is important information to know. Again, we are not studying to pass an exam. We are studying to save a life, okay, or many lives as a nurse, okay? I just want to point that out. Now, abbreviations and symbols not to be used in documentation, okay? There is an example on page 644, what you can use and what you can't use, okay? You'll look at this and you'll see on table 33.7 abbreviation, potential problem, and preferred term. We want the preferred term. We do not, this is the do not use list right here, okay? Not to be used in documentation. You need to write out certain things because it can be mistaken, okay? These are just good to look after, to look over, okay? Now, considerations for your older adult. Their metabolism, okay? What are they taking? How long have they been taking medicines? Who gives them? How do they get their meds? How do they organize their meds? How do they remember to take their pills? Okay? Your older adults are more likely to have differentiations or fluctuations in their blood pressure. Okay? They're going to become quickly more dehydrated quicker than the general population. Their kidney function as we age will decrease. Um, Financial resources, they're not working anymore sometimes, right? They're retired. Or maybe they don't have any money. Maybe finances are really strapped. We need to make sure that the doctor is not prescribing a medicine that they can't afford or can't get, especially in the area. Vision, have they had a stroke? Okay. If patient has arthritis and they have a hard time moving their hands, could you recommend an aspirin bottle with a rubber top for better grip, or are you just going to let them suffer with that clicky plastic slippery thing that they can't open? Okay. If they're non-compliant, there's probably a good reason. Okay. What is the underlying cause for them? Okay. Regarding patients that are in the home atmosphere, right? We need to make sure that they're able, um, one, to get their meds, two, to organize their meds, three, to understand their instructions. Okay. How can they, and you need to verify that they need these meds. If no one's available to give the med, how are they going to give it? You need to teach them. This is where the teaching aspect comes into place. Okay. Really, when you understand about the patient's medical problems, then you can start correlating the reason for the prescribed medicines. Okay. Assess if it's contraindicated. If giving a med affects the vital signs, maybe know the current readings before administering. So if they take a medicine to lower their blood pressure, teach them how to take their own blood pressure at home with an automated cuff. Okay, you want to make sure that they don't drop it too low or that it doesn't go too high if they're not feeling right. Teach them about the signs and symptoms. If they're not adherent, meaning they're not taking their med, maybe they just don't understand about the med. Or maybe they hate the side effect. They can't handle it. Okay? Again, financial? Or some people, they don't want to depend on a chemical to get well or maintain health. Okay? As being a developed country as the United States is, a lot of people are on medicine prescriptions because of the availability of it, the manufacturing of the drug. It's readily available, the prices of them. That's questionable. Most drugs, there are a lot of resources we have to make drugs available and affordable. So if your patient is non-compliant, non-adherent, please open-ended questions. Don't just go up and say why. Just ask them, is it finances? Is there what can I help you understand about the med? Open-ended questions. Okay. Always use your nursing process. Okay. Your drug book is going to be your best friend. Never give an unfamiliar drug. Absolutely. I tell you what, my first year of nursing, and even some of that, I remember I had my drug book with me, and to this day, people ask me drugs, and if I don't know it, I have to look it up because this is what our nursing practice is telling us. It says if you don't know a drug, don't give it. If you don't know a drug, look it up. It's not that, oh, I don't know it, I'm not going to give it. It's, excuse me, I'm on my next patient. Thank you. You go give it. No, you look it up and become familiarized with it. Again, introduction. Here's your rights. Memorize these. Okay? Right dose. Right drug. Right dose. Right route. Right time. Right patient. Right documentation. Always. This is not an option. This is always. 2 patient identifiers, name, date of birth. Okay, you can scan patients if you're in a long-term care facility and they don't have a scanner available, which now most of them do, but we still have some stragglers out there. Or what if their name is like a look-alike, sound-alike, or they're spelled the same but different first names? Things happen. You make sure you identify them with a picture if you're in a long-term care facility. Even some acute cares are starting to incorporate a photo. Why do we care so much? Because you are legally and ethically responsible for the patient. Make sure they're getting the right drug ordered by the healthcare provider or the doctor. Okay? We are the last ones to touch the medicine. Again, we are the last ones to touch the medicine. Doctor can order all they want, all day long, 100 orders. We're the last one to give it. Our hands are the last one to touch before it goes into the patient's system. And once they take it, there's no giving back. It is gone. It is in their body. They're going to absorb it. Okay? Think about that. Let that simmer. This is not on the test. Being very honest, this is you morally, ethically, legally responsible for your patient. This is a deep concept to understand. Okay? Very passionate about nursing, if you can't tell. And I want you to be equally as passionate or more. Okay? We need to protect our patients at all costs. Our job is to protect the public. Our job is to make sure that what we're doing is a safe and ethical and effective manner. Okay? Wherever you guys go work at, make friends with the pharmacist. Okay? Because they're going to help you. They're in the nursing world, they're our best friend. Doctor too, but I love my pharmacist. I love me some pharmacists. Let me tell you that right now. Especially if I'm waiting for a drug or I've got a real tricky question on a drug, pharmacist. Okay? Love my docs, but doctors visit pharmacists hold a special place in the heart. All right. Now, common nursing abbreviations. Again, you may see this in your practice. So this is extra, but it is stuff you need to know. Okay? Knowing what it means, how you're going to see it, how you may see it charted. Okay? Make sure you know the term pharmacokinetics. Let's see here. Okay, I'm sorry. Yep, talk about that. Just going over my notes, guys. Going over my notes. Let's pause on something real quick here. Oh, just lost my chapter. Hang on. On page 651, look at the picture, figure 33.3. This is a picture on how to pour pills from the patient's own supply. We do not take it out with our fingers for home care. Okay, it's poured into the cover. You can start practicing this at home with your family or yourself, just to get yourself in the rhythm and ready for clinicals. Okay. I would consider some clinical considerations before you start your clinical. If it is having the drug book with you. You may not need to bring it into clinical because your instructor normally has one for you, but you may, if you can, if it's economical, I would suggest a little pocket pharmacology book. Those are great. Like Davis makes it, Mosby makes it, but it's a little pocket guide. So when you're in clinical and your instructor is teaching you these different things, or you're in pharm and the instructor is teaching you different aspects of pharmacology, you have a little handheld book that you can refer to really quick. I still have mine. I loved it. It was amazing. Used that for a few years. Okay. What is the nurse's rights to medication administration? If inadequate supplies, insufficient information, insufficient time, or other systemic problems that negatively affect your ability to administer meds safely are occurring, you need to report those issues to the charge nurse and use a constructive problem-solving approach, because we just don't, it's about the patient. But again, we do have some rights in that aspect, okay? So, now, there's the picture I was talking about. And one more, your principles. Principles of med. This is very important. Now, whoever is pulling the med, or getting the med from the med card or from the med room is giving them. If you don't prepare it, if you don't draw it, if you're not giving it then. You do med pass from start to finish. If someone pulls it and prepares it, they need to give it. Okay? We do not leave medicines at the bedside. Absolutely not. I know that you guys have witnessed some way or another, if you're in the medical field, nurses that have left the CNAs to give medications. That is atrocious. That is not safe. Do not do that. If the nurse needs to, whoever is preparing the med and following the 6 rights needs to stay in the room until it's finished. Yep, I said it. Stay in the room until it's finished. That patient may have 18 drugs and they may take one by one and then oops, drop one, gotta go get another one. That's a problem, right? If the nurse was in there properly assisting the patient to take the meds, they probably wouldn't have dropped one and wasted their time. You have to check the medicines 3 times before you give it to the patient. 3 checks. Okay? You need to minimize distractions. Minimize. If your phone rings, don't answer it. Family member comes up to you screaming, crying, hold on, I'll be right with you. I'm passing meds. Unless somebody is bleeding out on the floor, cannot breathe, you need to minimize your distractions. Now, do not put my words into concrete. I'm telling you to minimize distractions, and I'm giving you examples. You need to know, when you're doing med pass, you need to know that med. In and out, action, dosage, anything that goes along with that med, you need to know about it. And like I said, if you don't, you're going to read up on it, and then if you deem that it's able to be given, you give it. Okay?